are expecting we are expecting a few more people to join. So we're just giving them a little bit more time. Thank you for bearing with us. Thank you everyone who has already joined on time. Just give us a little more time. Let's allow a few more people to join in and then we can get started. Just as exciting. So on behalf of Isha Special Interest Group for Private Practitioners in Audiology, I welcome you to a very exciting two-part series of webinar on expanding horizons for private practice in audiology. So today is the part one, which is going to cover the clinical aspect of it. And we are very fortunate to have a very interesting, very experienced international speaker with us, Dr. Imran Dhamani. I will be talking a little bit more. I'll be introducing him to you a little bit more shortly. And I request everyone to stick to the end of the presentation to get a sneak peek into an equally exciting part two of the same series. So before we start, quickly introducing you to the vision and mission of Isha's SIG's private practice in audiology. Our vision is to create an effective platform for communication, networking, healthy discussions, and sharing professional experience that foster excellence in private clinical practice. And our mission is to advance Isha's vision and mission by engaging members in activities that foster interchange of information among clinical practitioners. For this season of the SIG group, we have taken up the following aims and objectives: to work towards realizing aims and objectives of Isha, to facilitate scientific and technical advancements for the benefit of speech, language, and hearing afflicted population, formulate, develop, and implement common guidelines for clinical practice, share and adapt clinical tools for better clinical practice, facilitate research in clinical practice and develop research fund to promote clinical research, promote innovation and recognize innovative practice models, develop consensus on technical events, joint activities, and advocacies within the speech and hearing industry, recognize contribution of members in the growth of the profession, formulate guidelines for fair practice and curb malpractice, uphold professional ethics in clinical practice, improve awareness of profession among general public and other health professionals. So with that, let me give you a quick introduction to this year's SIG Private Practice and Audiology's core members. Of course, we have our President, Secretary, and Chairperson for Public Relations Alliancing. Mr. Saurav Nauka is our national coordinator, and along with him, Mr. Amit Anand is the joint coordinator. Apart from that, we also have our zonal advisors assigned to each zone. We have Mr. S.M. Tariq, who's the zonal advisor for North. Myself, Ms. Pragya Bharadwaj, I'm the zonal advisor for East. Ms. Neelu Somani and Ms. Rupal Chaudhary are the joint advisors for West and Central Zone, which is a huge zone. And we have Ms. Sherry Marcosa, who's the zonal advisor for South. So today, myself, Pragya Bharadwaj, practicing audiologist from Guwahati, and Ms. Neelu Somani, whom you all already know, practicing audiologist from Nagpur, we will be your host and moderator, and we'll try to make your experience today as interactive and as exciting as possible. So about today's speaker, we are very excited to have Dr. Imran Dhamani. He has done his PhD in audiology from Macquarie University, Sydney, Australia. He is a licensed practitioner and a member of the Australian Society for Audiology since 2012. And he's also a life member of Isha, of course. So Dr. Imran Dhamani is an experienced clinical audiologist at Amplifon, Australia, with over 15 years of global experience. He's also involved in clinical research with a focus on psychoacoustics of hearing, auditory processing, medical audiology, and digital signal processing. He has mentored several graduate students in clinical audiology as a clinical supervisor at Manipal University. and as an associate lecturer at Macquarie University, teaching courses on speech perception, electrophysiology, and psychoacoustics. So Dr. Imran Dhamani is the whole package with experience as in the educational sector, in the research sector, and in the private practice sector, that too in a corporate chain. So he would be able to give us some very interesting insights into how we can expand our practice in clinical audiology. So I welcome Dr. Imran Dhamani. The floor is all yours. We are ready to be blown away by you. Welcome, sir. So just give me just quickly before you start, I would like to tell our participants to please keep pouring your questions into the chat section. We will be taking up your questions, all of your questions at the end of his presentation, which will be roughly around 40 minutes. We request all of you to stick to the end of the presentation for the very interesting interactive session and for a sneak peek into the very interesting upcoming part 2 of the same series of webinar. With that, Dr. Imran Dhamani, please welcome, and the floor is all yours.
Thank you so much, Pragya, for such a wonderful introduction. I think I haven't had such an introduction since I was married a few years ago. so I think, yeah, I'm delighted to be here in front of all these private practitioners, and I'm sure there are other listeners as well. I just wanted to confirm before I start, is my voice audible?
Yes, sir, you are audible.
Okay, perfect. Thank you. So I was when I was approached for this talk, I was thinking, like when I'm in private practice as well, like what are the challenges that I face, and how can I actually tell somebody to do something that I might not be able to do it myself. And I was like, maybe I'll try my best and sort of give my perspective and ideas and all that. And then suddenly I was reading one of the quotes from one of my influencers, and this guy is called Kevin O'Leary, and he's a multi-billionaire in the world, and he quoted recently saying, ideas are dimes a dozen, but it's the execution which is unique and rare. So I'm thinking, if we talk about just ideas and not about execution, then what's the point? So that's why my focus on today's talk is more about execution. And I would really, enjoy and like a very active, casual discussion about what we are talking today, rather than just, focused at the academics of it or the research of it or whatever it is. Today, I thought I'll talk to you about, the theme today is expanding horizons in audiology practice. And obviously, I was involved in the past with a lot of pediatrics and cochlear implant audiology. But for the last few years, I'm more focused on adult and geriatric audiology. So I thought I'll focus more on what I know best at this stage. But of course, if obviously questions arise, we can always talk more about things apart from that as well. So I would like to start with some of the quotes that I really liked in this regard that I'm going to talk. One of those was, we must speak truth to power and confront ignorance with facts. Another one that I really liked was, avoid basing decisions on untested but strongly held beliefs, what you have done in the past, or on uncritical benchmarking of what winners do. And last but not the least, the truth of the matter is that you always know the right thing to do. The hard part is doing it. So I'm sure you would have got a hint of what I'm going to talk about. But let me start with something that we all kind of have thought about at some point, is the profession of audiology, and we as an audiologist. are we a clinician or are we a technician? And I'm sure, a lot of you would, in your mind or maybe just speak out saying, oh, obviously we are clinicians. But what does make us clinicians is very important sometimes to brood upon. And if we look at the proper definition of a technician versus a clinician, the technician is usually trained to follow protocols and routine processes. So if you consider pure tone audiometry or emittance or any of these equipments that we use, OAEs, ABRs, anything. And so they are just, equipments, and they are being used with a certain protocol that we follow, and the interpretation is done in a routine process. So basically just doing those tests and interpreting something out of it would still be considered a technical job. So then where does the clinical role really lie? So the clinician, due to fundamental knowledge of the human body and the ability to reason and assess evidence, can modify protocols to effectively respond to new and changing conditions. So, for example, if a clinician comes across something novel, something that is challenging their traditional protocols, then you should be able to adapt and change your focus and your technique and your treatment to modify it, and that's what makes us clinicians. So let's not forget, what does fundamentally make us clinicians. Um, a lot of talk that I will focus today is on what we call evidence-based clinical practice. And the reason behind that is that's the gold standard pretty much everywhere, in other healthcare industries as well as medicine. And I feel that that's one thing that will probably be the future as well for hearing healthcare, especially with how the competition in the field and the disruptors in the field are going. I think that's the only thing that will save the field, save the boat from sinking, I suppose that's how I'd call it. So what is evidence-based clinical practice? Evidence-based clinical practice is the conscientious, explicit, and judicious use of the best evidence in making decisions about the care of individual patients. So what we are talking about is pretty much, what we already know. It's not that we don't know about it, but whether we execute it in day-to-day practice is the question. So how do we actually, confirm to evidence-based practice is by using, of course, our clinical expertise that we have, the knowledge that we've learned in the universities, the experience that we've had, from whatever skills we've learned and honed over a period of time, along with, of course, empirical evidence from clinical research and data of what works, what doesn't work. And of course, patient preferences. So if you combine all the three, the empirical evidence, clinical expertise, as well as patient preferences, that's what actually makes evidence-based practice. So a lot of people might be thinking, yeah, but that's true, but that's all theoretical and that's what universities should do, not private practice. But I'm really talking about private practitioners here. And I think that that's what is going to keep us afloat in the future and actually make us distinct from other providers who are probably not as skilled or probably not as knowledgeable as we are in the field. So I thought, okay, let's just see what should be the standard. And I was fortunate to have this standard actually developed by Audiology Practice Standard Association. It's an organization which has been formed by a lot of private practitioners in the US and UK, and I think there's a few of them from other countries as well, and they have sat and developed, based on evidence-based clinical practice, they've developed some standards for hearing aid selection and fitting process. And that standard is called the APSO standard S2.1. There are about 15 points that they recommend. But today I'm going to only talk about a few of them, not all of them. But that I thought were quite relevant to what we are going to have the theme today. So let's talk about the first point that they recommend is that the fitting and selection of hearing aids should be based on a comprehensive and valid audiological assessment. Now, we all know that a basic audiological assessment involves clinical examination, pure tone audiometry, middle ear assessment, and speech testing. Now, within clinical examination, obviously it involves taking clinical history, observing signs and symptoms, understanding the listening difficulties of the patient using rating scales, quasi goals, things like that, doing a proper otoscopic examination, video otoscopy if possible, understanding client preferences and lifestyle. Now, the reason why I actually highlighted video otoscopy is that it actually makes quite a bit of an impression on the client, and it increases the trust and the loyalty of clients, because often you would get patients who have already been through GPs and ENT surgeons and all that, and been told, no, your ear is all right. And they don't really show them, what's inside, or, there's no confirmation of what the professional tells them. So when you can confirm that to them, saying, look, this is your ear canal on a big screen, or this is how it looks, if there's no wax, see your eardrums are healthy and things like that, it makes a huge impression, a huge impact. And I think that's one thing that I would definitely say is worth investing in as a private practitioner. So highly recommend that. And that's from experience as well. Pure tone audiometry, I would say, obviously, we do it for evaluating the type, degree, and configuration of hearing loss. Highly recommend use of insert earphones to avoid masking dilemmas. I know that a lot of practitioners, especially in private practice, sometimes are sometimes bound to cut corners with inserts, because of course there's expenses in terms of changing the tips and all that, because they are disposable and all that. But I do feel like having gotten rid of masking dilemmas does reduce the testing dilemmas, and also improves the validity of your reporting. And especially now that the practice, audiology practice, is so much disrupted and everybody's competing almost to the edge, that is very essential that the reports are really valid. And of course, if you have a masking dilemma, which is quite substantial, there is no other way out than to use insert earphones. Extended high frequency testing if possible. Obviously, not everybody has that facility, and maybe it's also a question whether it is worth buying something like that, a headphone specifically for high frequency testing. But often we see a lot of clients in some practices where there are people who have listening difficulties in noise or exposed to heavy noise and all that. And often you do a routine audiometry and you find normal hearing. So having extended high frequency gives you that extra sort of battery of test, which often people with such problems will fail. So that actually is a return of investment in that way, because you are getting some results out of that. And the same thing would be true for autoacoustic emissions as well, because often autoacoustic emissions are affected in those people at those high frequencies. CC, free field testing, and verbal and pulse tone testing if possible. I know I've mentioned CC and a lot of people think, how come you actually mentioned CC? That's been obsolete test and all that. But if you don't have autoacoustic emissions and you don't have ABR in your practice, CC is still actually quite a good test to assess at least that the person has some cochlear involvement. You can't rule out neural involvement completely with a CC test, but you can at least confirm cochlear involvement to a large extent with CC. So I don't think that we can just discard these tests. They're still important. And I feel that there's a lot of value that they carry. Middle ear assessment, Tympanometry and reflexes, obviously we all know that, but eustachian tube function testing, if required, is definitely an addition that I would highly recommend, because a lot of our clients may have like blockages in the ear and all that, and that could cause differences of airborne gaps of up to 10 to 15 decibels, especially at high frequencies, where eustachian tube dysfunction affects the most. And doing eustachian tube function tests also helps the surgeons or GPs to understand the problem and treat them properly. And of course, it improves, like I overall said, the validity of your services as well. And the trust factor across professionals also increases. High frequency TIMS for infants, if you are doing pediatrics, definitely recommend having high frequency tympanometry, because that's kind of the gold standard for infants now, for middle ear assessment. I'm not going to go into the details of that, but I'm very sure that most of you are aware what I'm talking about. Speech testing, speech tests in quiet to assess speech reception threshold, the speech discrimination scores, rollover, etc. So obviously, highly recommend that. If you're not doing it, please, definitely worth it. And I'm going to talk more about why these things are really worth it and good return for investment as well. Speech tests in noise. You can have spin test, quick scene test, and there's actually tests. These tests are actually converted into Indian languages already. So it's just a matter of you getting your hands on it and trying to do it. And you don't really need a formal test for it. And I'll talk to you more about it when I reach that topic. But definitely it's very simple to do, and you don't need to buy these tests. You can actually set up something like that, very simple, in your practice itself. So definitely worthwhile doing a speech in noise testing, because it's an ecological test. Think about this way, like most of the patients that come to your practice, their main problem is, I can't understand speech in background noise. I can't understand speech in a noisy place or in a group situation or in a social situation. And we live in a noisy world. So that's going to be the main complaint. And if you go ahead and put them in a booth, or maybe in a booth, maybe not, and then put headphones and then play tones to them and, test their hearing, there's no conformity to what their complaint is and what you're testing about. Because their complaint is mainly that they can't hear in noise, and you've gone ahead and tested them in a, completely isolated sound environment with tones that they're pressing buttons for, and then you're diagnosing them with their problem. So the validity of it is questionable, at least to the patient's perspective. It's like, me going to the doctor and saying, doctor, I have pain in my stomach. The doctor goes and tests my blood pressure and, tests my heart rate and everything, and doesn't even, check my stomach. What will I feel like? Maybe the doctor knows what they're doing and the diagnosis is correct. But for me as a patient, I'm like, well, I went with a stomach problem and he checked everything else except my stomach. So that's definitely one thing that I would highly recommend. Ecological testing, as we call it. Assessing UCLs, MCLs, listening effort. If you can do it, highly recommended. If you can't, that's fine. But definitely highly recommend speech testing in noise. So this is anyways the global standard at the moment that is recommended. The next thing, hide. Give me 1 second. Hide. Sorry about that. There was panels covering my slides, so I couldn't see it. Second recommendation from that standard for hearing aid fitting and selection was that patient communication is conducted in a clear, empathetic manner, consistent with the patient's communication mode, comprehension, and their health literacy level, and patient-centered care is provided. Now, when it comes to patient-centered care, if we talk about that first, what is patient-centered care? Now, mostly in most countries, including Australia, and I'm sure India would be on the same boat. most of the audiology practices in the past, and maybe even now, they follow a medical model. So what that means is that you combine clinical history with signs and symptoms, test results to reach to a diagnosis. Like you say, okay, what problem you have? Oh, you have hearing problem. Okay, you have ear pain. There's no clinical history. You were exposed to noise. Do a test and say, okay, you have high frequency sensory neural hearing loss. And then the clinician prescribes the solution, whether it's hearing aid, cochlear implant, whatever, based on the diagnosis and clinical data. But the focus is always on the impairment. Whereas the patient-centric model is where it is a client-driven interactive process of understanding real-life difficulties and corroborating it to the test results. So here it is not the clinician who drives the whole appointment. It is the client who drives, saying, okay, well, what problem you have? Okay, I rate myself this. I have problems in this. This is what I feel I want to do. So you are actually empowering the patient to make those decisions, for what he or she wants to do. And it's an informed and shared decision-making process about their hearing solutions. It's kind of how you would go into a retail shop, like buying a TV or a fridge or anything like that. You feel like that's kind of the process, but you are now incorporating a clinical component to it. So you're combining clinical and retail excellence in the same sort of way. And that's probably how that could be looked at. Like imagine you going to buy a TV or something and you have something in mind. And imagine you have a salesman, he comes like saying, oh, you know what, based on what I saw you and how you look, this is the TV I'd recommend and this is what you need to buy. Like imagine what your condition would be. Like, well, I'd go to another shop and buy. Well, that's kind of how the medical model feels like. Except that, of course, there's a cultural conformity to the medical model where people feel like we are doctors and they do want whatever we tell them. But really, is that what we really want the outcomes to be? Is the question. So patient-centered care leads to better treatment adherence, trust and satisfaction, and has been defined as being respectful of and responsive to individual patient preferences, needs and values, and ensuring that your patient values guide all clinical decisions. Some people may not agree to this and some people would, but I still feel like that's currently the global standard, gold standard across all healthcare practices. So there might be some truth to it. So it is better to conform to it sooner than later. So what are the attributes of this patient-centric model? So one of the attributes is that you acknowledge and understand the client as an individual first, rather than just the person with impairment. He's an individual. He has lifestyle, he has hobbies, he has interests, stuff like that. Then you have to make sure that the provision of information is appropriate. You can't be, you can't devoid the patient of information just because you think he or she may not need to know that. Ensuring client comfort, very important. Facilitating shared decision making, which we already talked about. And considering client motivation and readiness. That is very important because sometimes, a lot of inexperienced clinicians do not take that into account. And that leads to a lot of disputes and failures and rejections, which I'm sure some of you would have encountered already. So that's very important. Now, okay, this float screen is coming up. Okay, so why use patient-driven approach? Obviously, like I said, it's gold standard in other fields of healthcare, so why not? The focus is on management of the hearing loss instead of the person in medical model, which can often create stress and conflict because, as we all understand, hearing aids are both a consumer and a healthcare product. So whilst you feel like, sitting in your audiology clinic that you feel like you're a clinician, you are also selling some commodity like a hearing aid. So you want to make sure that there's not stress in that situation. It distinguishes the hearing aid uptake process from a sales approach, which is very important for the client to feel like that. It enables and empowers, the client, which is, or the patient, which is very, important for loyalty and trust. The clinician acts as a facilitator instead of a decision maker, improving client satisfaction and uptake of hearing aids. Client concerns are acknowledged and understood, which builds rapport and trust. And realistic perceptions of likely treatment effects are often, understood by the client. So that's very, very important. And if you look at most of the surveys that are done in that regard from MarkTrack, which is, European agency, which does a lot of surveys from actual hearing aid users and people who have got hearing loss and don't use hearing aids and things like that. And if you look at the most important reasons that people really buy hearing aids or stick to a hearing care professional is because they've trusted the hearing care professional and the hearing test clearly demonstrated need. And if you look at this patient-driven approach, it mainly focuses on building the trust in the patient. So that's the rated the highest in those surveys. And also the fact that the clinician considers your needs and abilities when recommending hearing aids, which is of course one of the factors that is taken into account with this patient-driven approach. And that's one of the highest rated in terms of why somebody would buy a hearing aid. So that's also very important to consider. Then the third factor in terms of the standards, they say is that a needs assessment is conducted in determining candidacy and in making individualized amplification recommendations. So what are these factors, that affect, candidacy for hearing aids and what hearing aids that we select for these patients? Of course, we know that there are, more of the environmental factors like distance, reverberation, noise that we have to consider. Like imagine if somebody, who's mainly having problems in background noise and we are recommending hearing aids, we have to make sure that we are recommending hearing aids with appropriate signal processing algorithms that can tackle that reverberation and distance, of course. Hearing profile type, of course, you prescribe hearing aids with enough reserve gain based on severity of loss, dynamic range, compression and all that, speech perception, tolerance issues. Of course, hearing aid efficiency also as well, and reliability and durability is another thing. That's another factor, but that's more of a client factor that is come across. Auditory processing limitations, like does the client have any processing limitations, peripheral or central, that has to be taken care as well in terms of the needs assessment. Cognitive processing ability, memory, attention, processing speed, all that has to be taken into consideration. Physical factors like ear shape, size, anatomical abnormalities, that also has to be taken into consideration. Medical issues like recurrent ear infection, surgery, wax, allergies. Like if the person has a lot of wax problems, you won't want to give them a hearing aid with a wax buster or wax filter in it that blocks often, and they have dexterity issues that they can't change all that. So it's better to give BTs to such clients, rechargeable, for example. Counseling, of course, realistic expectation, importance of aid use, cognitive benefits, avoiding auditory deprivation, all that also has to be taken into account. Client factors, again, there are factors like sound quality and performance. From the client's perspective, that has to be taken into account. Like if the client feels like, look, I don't like, my own voice to be, echoing and all that, then obviously you have to take that into consideration while, selecting the hearing aid. Psychological, factors like feeling, thought, motivation, expectations. Cosmetics is very important factor. Like if somebody says like, I don't want visible hearing aids, I don't want people to see hearing aids, then you have to go into that direction. Management, dexterity, handling, person is having, carpal tunnel, arthritis, some disability with the hand, they can't change batteries, high hand coordination is an issue, whatever, then you have to take that into consideration. Perceived listening difficulty, like that's another thing. Like if the person feels like, look, I rate myself a 10 on 10 for my hearing, but the wife or husband says, no, I think he's deaf and you need to do something about it. Problem is, if unless the person is motivated, themselves to and accepts that they have a problem, you cannot get good outcomes. So you'd have to tackle that barrier first before you go ahead and recommend hearing aids. And lifestyle and COSI goals, of course, are important, as we all know. So what is really a recommendation? So a recommendation is a proposal as to the best course of action, especially one put forward by an authoritative body. So a recommendation is usually, based on findings which are backed by strong clinical evidence or results. For example, if you have a newly diagnosed hearing loss for a client, we recommend early intervention due to negative consequences of untreated hearing loss, because we know from a lot of clinical studies, evidences that we know that early intervention is important and you have to do something about it early because of all the deprivation and all the cortical reorganization that happens. A suggestion, on the other hand, is an idea or a plan put forward for consideration. So a suggestion is nothing but a reasonable direction in absence of strong clinical evidence. So for example, if the client has, for example, a high frequency sloping hearing loss, relatively normal low frequency hearing, and we suggest open fit BT style hearing aids rather than customs, or avoiding occlusion effect, for example. Now, obviously, it's a gray area here because there's some actually clinical evidence to actually support that there is occlusion effect and all that. But still, there are clients who have high frequency sloping hearing losses who can get used to their own voice with that occlusion because they just want custom hearing aids. So that's not a strong recommendation, but that's more of a suggestion because it depends on, it's like a reasonable direction to take. So the recommendation and suggestion, there's a good sort of statement that I liked here, that you acknowledge the availability of alternative approaches when they're present, and to ensure that clients walk away understanding when our approach is a recommendation based on the best data we have, and when it's a suggestion in situations where reasonable clinicians may come to a different conclusion. So this is part of that evidence-based practice that I consider, that you have to make sure that you're recommending where it's required and you're suggesting where it's required. And it's very hard sometimes because there's a gray area between a recommendation and a suggestion. For example, you might suggest somebody that based on their listening difficulties, they might need a premium category hearing. But there's no strong clinical evidence to back that person will not get benefit from, say, a basic category hearing. So that's a suggestion, because he or she may go to another clinician who has different perspective. So you can't put that as a recommendation, but as a suggestion. Whereas on the other hand, if you think that person needs amplification because they are deprived of amplification, and you think that regardless of any the person going to any clinician or all, it's a clinical fact and there's a strong clinical evidence to suggest auditory deprivation and all, that could be a recommendation that we do think that you need hearing aids and things like that, and we suggest that this hearing aid would be best for you. So that's kind of what we call a evidence-based sort of approach to doing things. Now, how to recommend when there are too many choices? As you guys know, technological boom has created too many options for patients and clinicians. We call it paradox of choice. And that's not only in hearing aids, that's available everywhere. Like today I went to the shopping center to buy some stuff for groceries for my home. And I wanted to buy a pasta sauce. And for God's sake, I had 30, 40 options for pasta sauce. And I was calling my wife thinking, what brand you want, what flavor you want. And she just got upset because just buy something and finish it off. So the question is, when you have too many choices, it's not only the customer, but also the provider, which goes into this dilemma. So what do? Does offering more choices really translate to better decisions and happy clients? Not really. So offering more choice does not really translate to better decisions or happy clients. And this was a research done decades ago. And it is part of an accepted fact in psychology and consumer psychology. So what happens is when you give more choices to the client, these decisions require more cognitive effort, and it increases the chance of mistakes, and it causes more psychological consequences of the mistakes as well. Now, what does that mean? Like, for example, if the person makes a mistake in selecting the hearing aid that they wanted, say for example, instead of selecting um, a mid-range hearing aid, they selected a premium category hearing. Now, because of the number of choices that you've given to this patient, if the patient then for some reason is not satisfied with that particular hearing aid, the psychological consequence of that mistake that they think they've made is higher now. So that is another problem. There was a very interesting research actually done some decades ago by one of the psychologists, who what he did was simple. We said, okay, we'll have these jams of different flavors. So they had like 30 flavors of jam, and there are two shopping centers. So in one shopping centers, they put some people offering 24 choices of these flavors of jam to the customers who are coming out of the shopping center. And at the other shopping center, they said we'll only offer 6 choices of jam for tasting. Now, what happened in the end? Like, literally, when you look at it, you'll be like, oh, well, if you're offering so many flavors, there's more chance of people tasting and buying them. But what happened at the end was that the shopping center where you put 24 choices of jam, it attracted 60% of the shoppers. So for attracting shoppers, it was great. But only 3% of shoppers actually bought the jam. So as in a clinical perspective, if you think about it, you may attract a lot of clients because you're giving too many choices, but at the end, people who are actually buying from you are very limited because they just go somewhere else because they're just too confused. And when the 6 choices of jam were offered, it only attracted 40% of shoppers, but 30% of those shoppers ended up buying the jam. So even if you look at, like big companies like Apple and Google, if you see some of the apps they might be selling, you will see that there will always be 1 or 2, maybe 3 options. There'll be like a recommended option, there'll be an annual option, and there'll be something like a saver option or something. They're not going to give you too many options. And that's why, because then they'll always highlight what they recommend or suggest, and so that it's easy for the consumer to make decisions. And then comes the question of, oh, there's so many features in hearing aids nowadays: Bluetooth, app connectivity, artificial intelligence, this, that, and all. So that's what they call featureitis. Now, this was studied as part of the technological boom that happened, with all the other equipments as well, not just hearing aids. And they found that the subjective state of the consumer, when you offer them features, as you offer them more features, there's a sweet spot where the mindset is very positive. And after that, if you give them too many features, then the mindset actually drops and they get confused and they end up not buying things. So that's another thing to keep in mind. And the same thing with this graph as well, as you can see. So it's very important to limit the choices and try and use your clinical acumen to judge what the patient wants. Because on one hand, you might think, well, shouldn't I just give the client all the information that I have, but not necessarily it is going to be of any viable use to you. So how do we communicate the results? So one of the standards, that they had put forward is that the results should be communicated to the client at their health literacy level, like I said in the previous, slide. And what does that mean? That means that when we do audiometry, we do speech in noise testing or whatever testing we do, and we show these graphs to the patients, they are laymen. So for them, that graph is just like, oh my God, I don't know what this graph means. And when you try and explain to them in a nutshell in like 5 minutes or 10 minutes that you have, it's very difficult for the client to grasp, what you're trying to get at. And so most of the message that is conveyed is more about, okay, tell me what I need to do, kind of the message. So really that the thing that we want to convey to the patient is not really conveyed very well. So how do you get around that problem? So one way to get around that problem is that firstly, when the patient comes to you, you ask the patient to do a subjective self-rating of their hearing. So say, okay, well, on a scale of 0 to 10, for example, 0 being really bad, 10 being excellent, where do you see your hearing to be? The patient says, okay, I think I'm a 6 out of 10 or something. And then you can go into more situation specific, saying, okay, you said you have this problem in noise specifically. Okay, in noisy situations, where do you rate your hearing? I said, okay, I rate myself a 3 out of 10 in a noisy situation. And then he's like, okay, if somebody talks to you from behind, you said your wife talks to you from another room and you can't hear her or something, how do you rate your hearing there? It said 5 out of 10, for example. Now, based on all these information, you also can formulate a basic set of quasi goals, which mutual discussions. So saying, okay, to be able to hear my wife when she's not facing me and talking, or to be able to hear a conversation in a shopping center when there's a group of people and things like that. Now, when you do the testing, you convert your raw clinical test scores into rating scores to explain these results in a relatable manner. So for example, if you do a PTA testing, and say PTA comes with a moderate loss. So you can sort of say, all right, if you are checking the PTA from 0 to 120, so say if 30 or 40 decibel, you can do this thing in your own clinic specific, or you can just use the standards that are available. And you can say, okay, moderate loss is roughly 5 out of 10. So you said overall your hearing is a 6 or a 7 out of 10. I found it to be a 5 out of 10. That's relatable now, because the client has certain figure in mind and you are telling them, comparing that figure with your figure. So it's more relatable. Then you say, okay, you rated your hearing in a noisy environment to be a 3 out of 10. I did that test in noise that you remember, and I found it to be a 2 out of 10. So it's a bit worse than what you think it is. So that's kind of a relatable way of explaining to the patient. And that's one area that a lot of other healthcare practices are also doing a lot of research on, how to convey results to patients in a more relatable and efficient manner based on their health literacy level, because that increases the client adherence, which is basically meaning that the client would do what you ask them to do. So if you say, okay, this is what I recommend for you, they'll do it because they trust you now. So that's another factor. And of course, the subjective rating is also a good way of gauging where the person is at in terms of motivation levels. Like if you think about it, the PTA and the threshold information is not a really great predictor of self-perceived hearing handicap or readiness to pursue hearing aids. You might end up having somebody who is severely deaf, but not really ready to get hearing aids. And that's a common thing. We all face that. So then what is a good predictor of, hearing handicap or readiness to pursue hearing aids? So there was a research done on the subjective rating, and they found that the subjective rating is actually a very good predictor of hearing aid purchase independent of their hearing status. So you might have somebody with a very, very mild loss who's rating their hearing a 4 out of 10 and may end up purchasing hearing aids or doing something about their rehabilitation. And you might end up having somebody with severe hearing loss rating their hearing a 9 out of 10 and doing nothing about their hearing. So that's also very important in that aspect. And that's why I'd highly recommend doing subjective ratings. And you can see that on the graph as well, which is shown, the same thing that I mentioned to you about. Next thing is to, while you're communicating with your patient, it's very, very important to consider barriers. Like I talked earlier, motivation and cost are usually the most common barriers which are identified. If you look at, the mark track survey results from, say, for example, non-owners who have taken no steps, which means that these are people who have hearing loss identified by a practitioner, but they have not chosen to buy hearing aids. And you can look at the highest reason why they didn't do it. Can hear well enough and too expensive. So can hear well enough comes back to a motivation barrier, and too expensive comes down to the cost barrier. So that's another thing. So then if you look at non-owners where healthcare provider or hearing care provider recommended hearing aids, again, too expensive and cannot afford, common factors, again, coming back to cost and motivation being the main sort of reason why people don't get hearing aids. So tackling that is very important. Now, it's easy for me to say, okay, you have to tackle it, but how do you really tackle it? How do you tackle somebody who's not motivated to get hearing aids? Now, let's consider hearing aid acceptance as a behavior, like any other behavior. say for example, I have my kid who is, say for example, 7 years old, and I want him to change a certain habit that he has. Say maybe I want to make him change his habit of, say for example, eating chocolates. So there are some stages of change that are developed by psychologists and behavioral scientists. And if you look at this chart here, you can see that cycle here. So the first step is what we call pre-contemplation phase, which means the person has no intent on changing a behavior or attitude, which means I don't have a problem. Which means, like, imagine if I tell my son that, look, you are eating too many chocolates, he'll be like, I don't think I'm eating too many chocolates. So that person is now at the pre-contemplation phase. Can you tackle that person at that phase? It's going to be very, very difficult. And we're going to go into details of it as well. Then the next step is what we call the contemplation phase, which means that the person has awareness of the problem, but lacks the intent, commitment, or ways to implement the behavioral or cognitive change, which means like something like, I know I have a problem, but I'm not ready, fearful, or unwilling to do anything. That's a slightly easy phase to tackle for a clinician, but still a hard one comparatively. Then comes the preparation phase, where the person has a desire to change and looks for ways to implement it. Like, for example, who do I know who has dealt with this? Let me Google some ways others have done this. What type of a therapy should I see? Kind of thing. And then you have the action phase, where a lot of people might be at the action phase, where the person takes the steps they need to achieve the change they seek, like going and seeing an audiologist for the hearing and things like that. And then you have somebody in the maintenance phase, where the person continues to do the same behaviors they need to maintain the change or enhance it in order to prevent the reoccurrence of old learning or relapse. So the whole idea is that to start somebody from a pre-contemplation phase, and then going from contemplation, preparation, action, to making them reach the maintenance phase where there's no relapse. Pretty much that's pretty much the idea of a change in behavior. So think about hearing aid acceptance as a behavior. That's what we are trying to tackle, and it's a huge sort of challenge. Now, how do behavioral scientists deal with this? They deal with this with something called motivational interviewing. And they have these steps called RULE, rule, as they call it. And how they do it is that, with R, they call it resist. So you resist telling them what to do. You avoid telling, directing, or convincing the person about the right path to good health. So it's very important in motivational interviewing that you're not telling people. And that's, of course, going back to that patient-centered care, that you're not telling the person, because that becomes more of a medical model. Because you're telling, like, this is what I want you to do and this is what you should do. And that's where, it creates conflict, because the person is not motivated anyways and you're trying to create conflict again. Then U is for understanding, understanding their motivation. Seek to understand their values, needs, abilities, motivation, and potential barriers to changing behaviors. Like, so for example, if I have a patient, that the day before yesterday I had a patient, and the patient has absolutely no motivation to get hearing aid, but just trying to sort of understand more from the patient, he came out saying, look, the only reason I'm here is because my wife said that I'm deaf and I need to get hearing aids. So that came up with that thing that, okay, well, that is that person's values, that person's needs, is that he wants to do something to change that behavior, which is the hearing loss, just because of somebody else, which is fine. That's their value and we respect that. And we still ended up with a good outcome. Listening with empathy, which is the L. So seek to understand their values, needs, abilities, motivations, and potential barriers to changing behaviors. And last but not the least, E, which is empower them, work with them to set achievable goals and to identify techniques to overcome barriers, which is what we are talking about. So in terms of our actual hearing aid sort of reference, you could look at saying that, okay, let's say somebody is at a pre-contemplation phase. He or she would be like, I'm not ready for hearing aids at this time, right? So in that case, whatever information you're giving them, whatever education you're giving them, really is not getting, a lot of outcome from it. It's not sort of giving you that much of a, how do I say, value, right? So you have to then assess which phase the person is and what you really need. Now, if the person is in the next phase, which is the contemplation phase, again, they would be like, look, I have been thinking that I might need hearing aids. So in that case, information education could help. Advice, maybe not, because they're not ready for that at that stage. Then you may have somebody at the preparation phase, which means they might be thinking like, I've started to seek information about hearing aid, which means when they kind of know that they're there. And at that point, advice, information, education, all three help a lot, right? And encouragement to some extent. And then you have somebody at the action phase of motivation, where saying, I'm ready to get hearing aids if recommended. So at that point, all that education, information, advice, encouragement, all that is really useful. And then you may have patients who are finally ending up into the maintenance phase, which means I'm comfortable with the idea of wearing hearing aids. And in that case, they need everything, and everything will have positive outcomes because it's all useful and will give value to that patient. Does not mean that you don't encourage somebody or you don't support somebody who's at the pre-contemplation or contemplation phase, but at least as a private practitioner, you want to know where your time is invested in. So that's very important to understand this process. You can also use these motivational tools that have been created from different universities, where like how important is it for you to improve your hearing now. So they rate themselves from 0 to 10. How much do you believe in your ability to use hearing aids? So when they rate, and you, based on the rating scale, straight away what motivation levels they have. And same thing with this is what a cost versus benefit kind of a tool is there, and you can probably use something like that as well to overcome that barrier, or at least understand the motivational levels of the client. What about refits? Now, if you have already somebody who's using hearing aids, and you want this person to, really, get new hearing aids. So how do you, evaluate them? How do you actually get more, value for your time? And how do you tackle that issue? So there was a interesting theory proposed by Rogers, called the adoption and diffusion of innovation theory. And what he says is that, whenever you have something new that you're proposing to somebody, there will be a bell-shaped curve, right? A bell-shaped curve basically means that there will be some people who are innovators, which means that for them, even a small advantage, they will go to that next phase. So say, for example, you may have somebody who's using, say, for example, a highest level premium category hearing aid 2 years ago, and they see like, oh, there's one feature extra, two features extra in this new hearing aid. They may see the relative advantage and they may buy it. So these are called innovators, right? Then you have something called early adopters, which are around 13.5% of the population. And what these people are is basically those people who would wait for these innovators to do something, and then they will kick in, because they are looking at confirming and compatibility. So they just want to confirm and say, look, hey, because my friend got it, I am also getting it, because they liked it, I think I'll like it as well. So that's kind of the early adopter group. Then you have the early majority, and the early majority, the focus is to complexity. So like how easy my task becomes with this new thing. So you have to focus on that for those people. Like it's and believe me, it's very hard to understand who is an innovator or who is in this phase or this phase. It comes with experience, and sometimes you even get wrong even after years of experience. But still, at least knowing that helps us, tackle the patient at hand better, I suppose. So for them, you want to make sure that you're making the task easy with that new hearing aid or whatever you're proposing them. Then you have the late majority, and the late majority and the laggards as well. So that consists of you can see, almost 50% of the population. These are late majorities and laggards. And for them, triability and observability is key, which means that you have to offer them a trial before they can be convinced that, okay, they need a new hearing aid. and they might even observe 10 people after the trial to convince themselves that yes, this is what they need to do. But at least this diffusion of innovations theory is important, according to me, to understand what client behavior or patient behavior is in terms of these things. The next recommendation from that standards in terms of hearing aid fitting and selection was that the recommended hearing aids include signal processing and features that support patients' needs. You can see, like, nowadays there's so many signal processing features available for different client preferences, like sound quality. You have improvements in bit and sampling rate, processing delays have reduced, stuff like that. Performance and clarity, the chips are getting smaller, hearing aids are getting smaller, you have wind noise filters, echo cancelers, greater input dynamic range. In terms of management and comfort, you have things like dual compression and machine learning and artificial intelligence and auto on off features and acoustic analysis and classification, stuff like that. I don't want to go into details of it because that's another lecture in itself, but there's so many things that we can recommend and do. But like I said, this is very important to understand in conjunction with that paradox of choice, because sometimes we often feel that the paradox of choice is only at the level of the client or the patient, but it's also at the level of the clinicians, because if you have too many features and too many brands to choose from, you often will get confused and you may not be able to recommend the client properly or suggest the client properly what you really want them to do. Fifth recommendation is assistive technology and accessories are considered to facilitate accessibility to other devices and to satisfy the patient's listening and communication needs. So always recommended is to consider use of ALD systems such as FMs, remote mics, smartphone apps, captioning, listening devices, etc., based on patient needs. Of course, you want to avoid too many accessories, especially if somebody has management issues. So that's another recommendation. I'm sure we are all on the page for this and we all do it at times. But if we are not, I'd highly recommend it because it does make a difference, especially for those who are not getting benefits from traditional approaches. An assessment, the next recommendation is an assessment of initial product quality is completed using standard electroacoustic measures to verify either manufacturer or published specifications. Now, this is a controversial topic, I believe, because a lot of people will think, okay, in private practice, why do you need a hearing aid, hearing instrument test box, a HIT box, as we call it? Why do I need to assess electroacoustics when I'm getting a new hearing aid from a manufacturer A, B, or C? They are trusted manufacturers. I'm presuming that the hearing aid is pretty much in good condition, and really, I don't need to do it. The problem is it's a very useful investment in regards to facilitating refits based on older technology, older hearing aids due to wear and tear. Because often, if the person comes with a 3, 4, 5-year-old hearing aid and you say, oh, your hearing aid is too old because it's gone wear and tear, this and that, you're telling all that, but there's always that bias, right, in the patient's mind that you're trying to sell them a hearing aid. So how do you actually objectively test it? And then the patient becomes more convinced that really what you're telling, like that your money is on the ball, as they say. So when you do these tests, you can actually prove that there's a mic drift. Therefore, the noise reduction capacity of the hearing aid is reduced, or there is poor microphone sensitivity, or there is high total harmonic distortion, or equivalent input noise levels has increased. And also very handy to assess these electroacoustics for those who have ended up buying hearing aids from like non commercial brands that are existing, or OTC hearing aids which are non-prescription quality. Like you might end up, say for example, prescribing something like, what I think I need, I would suggest you to get a mid-range hearing aid from, say for example, XYZ manufacturer, a prescription quality, and they say, look, I bought this hearing aid online or from the optical shop or whatever XYZ shop nearby, and I only bought it for 500 rupees or 1,000 rupees, and it works. So why should I end up buying 1 lakh rupees or 50,000 rupees of hearing aid? When you do electroacoustics and you can actually show on paper that the electroacoustics of that hearing aid is pretty crappy, it's easier to convince your patients. And of course, with the disruption in practice nowadays that I think is going to happen, very soon, this is going to be the key and a good return for investment. The next recommendation is that hearing aids are fitted so that various input levels of speech result in verified ear canal output that meets the frequency specific targets provided by a validated prescriptive method and ensure that the output does not exceed the patient's loudness discomfort levels. Now, again, a controversial topic because a lot of people would be not doing real ear measurements. They'll say, well, I've seen a lot of people doing quick fits. People are very happy. They've prescribed thousands of hearing aids. Why should I even bother? And that comes back to my quote. If anybody of you remembers that quote, that having an uncritical approach to accepting what a winning strategy is actually not right. Because just because somebody does it doesn't make it the right way of doing things. Now, quick fit approach differed significantly from prescriptive null NL2 targets. Now, I'm talking about just one study. I've gone through almost 79 studies which have proven this. So I didn't have time and to accumulate all the studies. So I didn't even put references there because, of course, I'm talking to a crowd of private practitioners. I don't want to put too many references and all that, because for me, it's more the impact which is more important. And that summarize the results here to say that quick fit approach underfits by roughly 7 to 10 dB across input levels like 50, 65, and 80. Despite you selecting the experience fitting formula of choice in the programming softwares, and this is across all the big brands. I'm talking about all the 5-6 brands you might be fitting. The REM approach, or the real ear measurement approach, provided gain within 1.5 to 2.5 dB across input levels from the null NL2 prescriptive target, right? And I know some of you guys might be saying, oh, but I use NL1. It's the same. Like I said, there are 79 studies that includes pretty much all the prescriptive formulas you might have used or you are planning to use, even with programming allowances to address participant listening preferences. Now, what does this do? What does this discrepancy do? You'll be like, okay, 5-7 dB here and there. How does it make a difference? These differences result in poor aided speech intelligibility index scores, and they've been proven in quick SIN and spin tests and all the different kind of BKB SIN tests and all that they do in the lab across, like I said, 79 studies to prove that these patients who are fitted with quick fit approach over the REM approach, they have poor overall speech intelligibility and noise. Again, equals poor client satisfaction. Now, if you have a poor client satisfaction, of course, it will lead to rejection of hearing aids, returns, and sometimes if the client doesn't come back because they're just too embarrassed to return it or whatever, then in that case, they might just keep it, but then there is no word of mouth publicity for you because they might go and tell others like, I got this hearing aid and it's not helping me. So it's very important. And I think it's a very good return of investment. So why bother with investing in real ear verification equipment? Because obviously it's very expensive. I don't know how much exactly it will cost in India, but obviously it could be a big affair. So why even bother? So it was a very good research done by Amlani and colleagues, and actually a lot of others have done this, but I just picked one study just for explaining what I wanted to convey. So he studied patient loyalty factors using real ear measurements. Because theory we all know in theory. I don't want to go into detail of why we need real ear measurements. We all know they are important, but we are not doing it. So why then invest in it? So they assessed the relative impact of the fitting method on patient loyalty, which is an important issue for practitioners. The results suggested that the real ear verification approach enhanced all three aspects, which is advocacy, purchasing, and retention, which is part of the patient loyalty, compared to the quick fit approach. Because the patient is seeing you doing these things, and they might have gone somewhere else, they might have not got all that experience. That makes a huge difference in terms of the patient loyalty. It also improves the perceived value of the provider in the eyes of the hearing aid user. Because if anybody off the street is now selling hearing aids, how do you distinguish yourself in the eyes of the person who's come to you as a clinician to buy hearing aids? So this increase in perceived value then lends itself to increased purchase and repurchase intent of services and products, which obviously we all want. And it also leads increased referrals through patient recommendation, because that patient will go and tell others, say, what last hearing aid I bought, they just put the hearing aid in my ears. They just said, how is it? Everything's fine. And I went, and here they took like half an hour, 1 hour to, adjust it, did all these tests and all that. And, I was so impressed. You should go to them because they know what they're doing. Makes a lot of difference, hell lot of difference, believe me. It also enhances the practice's reputation and brand, because right now brand is everything. Reputation and brand is king, especially in a disruptive market. So while reducing the time and expenses associated with marketing, it is trying to increase your reputation and brand without actually paying, like top dollars to do it. So in this time of disruptive innovations and evolving service and product delivery models, like people buying hearing aids from everywhere and anywhere that they can get their hands on, the clinician would be wise to consider the integration of clinical services, including this real ear measurement, speech in noise testing, like I said, that will enhance their perceived value and highlight the important role they have to play in hearing healthcare delivery. I put the graphs. If somebody wants to ask questions later, I can explain, but that's the graphs for the results of that loyalty, factors that they studied for that study. The next recommendation that they had was that hearing aid outcome measures are conducted. These may include validated self-assessment or communication inventories and aided speech recognition assessment. Now, validated self-assessment is like a COSI, like client-oriented, goals that we all know. There is a set of, goals that you create with the client saying, okay, what do you want to achieve out of your hearing aids? And then after fitting the hearing aids at the follow-up, you ask them, okay, compared to what you rated yourself, how do you feel? That's a good thing. But what I'm trying to focus here is validation using free field speech and noise test. And I know hearing this, a lot of you guys would be like, oh, that's too complicated. That's, I'm not in a university setup, but simple private practitioner. I can't do all these complex. And I can assure you it doesn't need to be too complicated. Just a simple and short test with basic equipment and minimal calibration. What you do is just simply assess unaided scores without the hearing aids and aided scores with the hearing aids. It's very effective in demonstrating objective measure of improvement and very effective in convincing less motivated patients, especially when carers are present. Because imagine you have the wife here or the husband here, with the client, and you are doing this test without the hearing aids. He's only getting 50%, and the carer is hearing 100% of what's being said. And then you put the hearing aids, and now both the carer and the client is hearing 100% of what's being said. Makes a huge difference. But then you'll say, well, then can't I just do speech in quiet? Why would I have to do speech in noise? Again, coming back to the same ecological assessment, you need to make it realistic, because the person is not going to hear things in quiet. The problem that they have come up with, or at least their carers are talking about, is not in a quiet situation. So why would you assess them in quiet? Number one, so it's not relatable. Second thing is that especially if you have minimal losses, mild losses, sloping losses, when you do speech in quiet, it is very hard to see a big difference between unaided and aided scores, because it's not really going to show a big difference, because normal conversational testing that you do in speech in quiet at 50 dB or 40 dB is not going to see a big difference. But when you have speech recognition and noise, and suddenly now you are starting to hear normally with the hearing aid, makes a huge difference. So I think with both that factors, I think it's very, very effective. And it's also useful when documented as evidence of benefit in a medico-legal dispute. Like imagine if like after 5 years, 4 years, the person goes into a dispute saying, oh, you gave me the wrong hearing aid or something. You have evidence saying, we've done the objective testing, we validated it, and, here's the score. So it just safeguards you as well. So that's that. The next recommendation is that short and long-term follow-up is conducted to ensure that post-fitting needs are addressed. This includes updating audiological assessment, hearing aid adjustment, routine maintenance as needed to ensure the devices are functioning properly and appropriately for the patient. Now, a lot of private practitioners might think, hold on, why should I call the client again? I've sold my hearing aid, I've done the hearing test. Why would I even bother calling the client again? Is it even worth my time? I think it's very worth, because it's very useful in creating a loyal patient. Following which he would purchase and repurchase the hearing aid and would recommend others. You can offer services like electronic dehumidification. I don't know if most of you have heard about this new thing called Redux. This is a dehumidification, electronic dehumidification machine where you can actually put the hearing aids in and it records how much moisture is collected from the hearing aid and actually gives you a printed record of it so that you can give to the patient. So this is also very good in attracting patients from other providers because they may not be providing it. So if you provide it and you give a written sort of document that this so much of water came out of the hearing aids and now it's working pretty much well. And if you on any addition to that, you have a heat box as well that you can do electroacoustic measurements before and after the moisture reduction. That's a huge impact and people won't even mind paying for that appointment in that case. And so you've got a service delivery model established for follow-ups where you don't really need to sell hearing aids to earn profits. And plus you've got these patients from other providers where you can then, convert them as your loyal patients. Auditory training can be done. A lot of clients who have problems with hearing in noise and all that, not necessarily all of them can be helped with better technology. Imagine they are wearing the best premium quality hearing aids, which have just purchased 6 months ago, and they're still facing problems. What are you going to do with it? I mean, changing brands is not going to do much. I mean, unless obviously there's something really wrong. So if you can offer them auditory training where you can, charge them for that service, it's a good model and it's a very sustainable one. Same thing with hitbox testing, hearing retests, aid adjustments, revalidation of aided scores. Like imagine if somebody comes to you saying, oh, I'm not happy with my hearing aids, I bought it elsewhere. Yeah, well, sure, charge them for the service and do a revalidation of the aided scores, do a speech and noise test. They'll be happy to pay for it. So I think that in this time, it's very important to establish alternative delivery models of service rather than just fixating on hearing aid sales. But that's just my personal view. And of course, advanced specialized clinics are also the future, I feel. Vertigo assessment clinics, pediatric assessments and hearing aid fitting clinics, cochlear implant clinics, auditory processing assessment clinics. You can just extend your practice to incorporate these, or you can do specialized practices for this. I think there's a huge scope for these things. With that being said, that's the end. That's what I wanted to talk to you guys about. Thank you for listening to me patiently on a Sunday morning, afternoon, wherever you are. And yeah, any questions, I'm happy to answer.
Thank you, Dr. Imran. That was an exhilarating talk from you. Thank you for your insightful recommendation, putting them in very practical clinical context for us to understand. But we can't let you go yet. We have some very interesting questions pouring into the chat box. And I now welcome Ms. Neelu Somani, madam, to kindly take us through the discussion round, take up the questions and moderate the discussion round.
Thank you, Pragya, and thank you, Imran, so much. I was just glued to the presentation, and I hope all the attendees have been so. And that was really justifying to the topic, and the vision of today is like expanding horizons. And truly, it's like you rightly said, we have to start, and we have to start making a difference, right? And we have to right there, as you rightly said, cope up with, and we are in competition with, of course, not only other clinics, but even non-audiologists and all the other practices also that are going on here. I'll quickly take up some questions which were in the chat box, and then maybe we can add few more questions as they come up. So this is one question that came. What's the treatment protocol for individuals with signs of early high frequency hearing loss? And do we have any baseline to consider any abnormality? I'll read up again. What's the treatment protocol for individuals with signs of early high frequency hearing loss? And do we have any baseline to consider abnormality?
Yeah, that's a good question. So I believe that's in context to when I was talking about high frequency testing,
yes.
extended high frequency testing. So there's actually one of our colleagues from forgot his name, but he is in the US, and he is doing a lot of work in doing this, establishing the norms for extended high frequency testing. And I think he's got a publication recently. I was just reading on it. So there's actually norms available for um, testing people from 8,000 to 16,000 hertz. So yes, you have baseline, you have norms, and you can actually assess patients using those norms. So it's very interesting actually field, because a lot of patients that come to our practice, for example, they are, say for example, they come from noise exposures from the army and things like that, and they have absolutely normal hearing from 250 to 8,000 hertz, but they come with listening difficulties, and it's very challenging sometimes for us to tell them, look, I know you have a problem, but everything comes normal on my test. Like reflexes are normal, TIMS are normal, audiometry is normal, speech in quiet is normal, even speech in noise sometimes is normal. So what do you do? So extended high frequencies definitely has a lot of scope in advancing your private practice. Yes, it would depend on the kind of clientele that you see in that particular region. But yeah, if you have such clientele, definitely highly recommend. And yes, those norms are definitely available in the article format, as well as if you buy it from any manufacturer, they would have their own norms as well.
Okay, so could you, is it possible for you to share the link to that article? Then maybe we can forward it, or we can have it on the chat box as well.
Absolutely, absolutely.
Yeah.
I will.
Okay. Now, so there was another next question is that you mentioned about the CC, but the newer audiometers, I don't think so they have the CC test facility anymore. So then what should we do? Like, I mean, then it's about going to an OE and an ABR assessment?
Of course, like OE and ABR, if you can afford it and if you have the option, I highly recommend it, because see, like I said clearly, CC is only for those practices. For some reason, they can't afford to buy OE and ABR. If you can afford to buy an OE and ABR, 100%, there's no replacement for it. The whole reason why CC became obsolete in, Jerger's own eyes, because he's the one who developed the test from scratch, is because of the establishment of OAs and ABRs. That's where everybody thought, well, if we can assess the cochlear reserves that ways and the neural reserves that ways, why even bother doing CC? But the question about CCs not being available in new audiometers, well, I have an Oracle 2 here, which I believe is not too old, and I have CC in that, and I know interacoustics audiometers have that as well. So I don't think they have become obsolete. Even newer audiometers have it. You just have to ask the manufacturers to give you the test. The test modules are there. They just probably don't give it in the basic versions.
Yeah, so you rightly said the newer audiometer, or I would say the entire clinical audiometer, what they call, they come with these patches, and you can ask them what are the special tests that are required. And accordingly, I think the cost of the audiometer, they vary. So
yeah.
Yes. Okay. Now, the next is like kind of just exemplifying on the fact that speech audiometry is essential, but can you give us more practical tips on speech audiometry? As in like, okay, we know that the entire test battery on the speech audiometry, how important is, but can you give us some practical tip how to make it more doable and encourage private practitioners like to get, because most of the clinics, I would say maximum clinics really don't have a setup for speech audiometry.
See, it's very simple. The way we do it here is like the patient sits on the chair, right? And we have two speakers, one on the back, one on the front, on the wall. So it's a wall mounted speaker, and you can buy any cheap speaker you want. Like you don't need to have a Bose or a Sennheiser or anything like that. You can have a cheap speaker as long as you are happy with the performance. And you keep the person 3 meters roughly away from the speaker. And most of the modern audiometers are 2-channel, which means that the one channel you can have the sentences going from one speaker, and the other channel you have noise going from the other speaker. I would recommend if you can have babble noise instead of just narrow band or white noise. It's always more realistic to have babble, and most audiometers will provide speech and noise test embedded in it, so you don't even have to do much about it. They are all 2-channel. They have speech and noise module in it. What you need to do is just have 2 speakers wall mounted, and just if you do a spin test, the way you can modify the spin test is like, obviously we all know that spin test has 25 sentences you present, and then you have low context and high context. You don't really need to go into all that detail. You're not doing a clinical research or in a university setup. What you can do is just shorten the list and combine high and low context sentence to a short list of 10. That's what we do. And then present those 10 sentences, unaided and aided, and that's it. So if the person unaided gets 5 out of 10 correct and aided he gets 7 or 8 out of 10 correct, there's an improvement of 30% there straight away. So that's one way. If you want to use QuickSyn, you can buy QuickSyn modules for most audiometric manufacturers. So you can do QuickSyn as well. QuickSyn is where you have these sentences and all, but I don't know if the manufacturers of audiometers in India provide the Indianized version of QuickSyn and spin tests. So in that case, you may have to probably contact the universities, like Aish and Manipal and whatever, AYJ and all that, wherever you are located. And you can just take the local version of whatever, like there are heaps of people who would have dissertations in trying to convert, an English test into local languages. You can just use that and just call the manufacturer's, technician to come and install it and just try and get it working. Because if you have a sound file with all those recorded sentences and babble, it is just the technician will just come and direct which channel the sound file has to go, and they'll be able to set it up for you. It's very simple. Honestly, it's as simple as just picking the phone and trying to call the technician, and sometimes those technicians are in touch with the universities. They might be able to do the job for you entirely. You don't even have to contact the universities for it.
Okay. So thank you, Imran. What I understand over here is that we just spoke about the speech and noise testing, and where you said that we need two speakers. One is, of course, in the front, and the other is directly back in the behind. And we can use these different sentences. And yes, there are sentences here in Indian languages which we are using for speech and noise testing. There are standardized sentences as well. But like I can share my example. What I have done here is I have taken a set of sentences and tried to like use them in the local languages as well. So that works pretty well when we are doing a practical fitting. And yes, agree to you that not everything has to be kind of like for research in that sense. So that was really very useful. The next question is, what's the average time per client you would spend in your day-to-day clinical practice? Considering that there's so much to do now. Yeah.
It depends on the return of investment, isn't it? It all comes back to what you think the clinical value for that time is. So if I have a patient whom I feel has a lot of listening difficulty and probably is potentially needing more rehab than usual, then I'd invest a little bit more time in them. And somebody who's probably requiring less rehab because they have less difficulties or motivational barriers, I might spend less time, but maybe not even less or more. It's more about how you spend your time rather than how much you spend.
I
But
think the
honestly,
question, I'm sorry. I think the question is more related to like, I would probably understand, goes by you assessing the client's motivational needs and then accordingly giving him more time towards, maybe a conversion like, or a fitting of a hearing aid. Yeah.
Yeah, that's right. I mean, you go by patient to patient. You can't have a ballpark figure for it. But normally 1 hour, 1.5 hours is more than sufficient for most of those.
Okay, thanks. So the next question is, what's the magic number of the number of units sold in private clinics, like approximately, which are 5 years and older, and which is more a clinic which is functional for more than 10 years, like that way? 5
Sorry.
years and 10 years. What is the magic number of the units that will be sold in a private clinic? Especially when clinics which are older, like, they're legacy clinics, like 5 years, 10 years old clinics. What would be the number of units sold in these clinics, hearing aids?
So you mean to say what is the chances of people actually doing refits? Is that the question?
Yes, could be.
That all depends on the, like I said, it all depends on the service delivery model, we building the adherence, the loyalty, the trust of the patient, how we are actually proving to the patient that why they need to change their hearing aids. And sometimes it all comes down to first time counseling them. Because if you give them the hearing aid saying, oh, ye 10 saal chalega, 20 saal chalega, because just you want to sell the hearing aid. Well, you've put the X on your own foot then. So it all comes down to how you build that, case as well. Because if you're going to run that clinic in that region for the next 10, 15, 20 years, you might want to, go in a cautious manner of how you counsel your clients, how you have your service delivery model, how you build your trust, in the clients, how you build a loyal database of the clients, and how you can prove to them. Sometimes trials are the best way to do it. Sometimes it's very hard to convince somebody to buy a new hearing aid in 5 or 6 years. You just have to ask them to try it, and sometimes the device and the technology speaks for themselves, and you don't have to do much counseling, and sometimes it is counseling which helps. So it all is patient to patient, and I'm sure all of you might agree with that.
Yeah. Yes. Next question is, how many average footfalls are seen in Australia?
Footfalls depends on the region. In regional Australia, it's different. Then it comes to more ASP that we work on, and in bigger metropolitan cities, the footfall is high. So you can't have a ballpark figure, but yeah, we say, for example, footfall in a regional clinic like mine, you might be looking at maybe 2,000 people in a year, 2,000, 3,000 people in a year.
Okay. So this next question is really interesting. It would be interesting to review or debate if performing a comprehensive battery of tests can still be considered a patient-centered approach. For example, if a practice doing a full battery of tests could be considered patient-centered, and that's what is going to sustain a clinic in long term, then why are the new age retail model hearing aid chain of stores attract more patients or customers than the universities or the institutions?
That's a good question. There's always going to be that component of cost that is involved, of course, in those things. There's always that, marketing definitely involved in that as well. Like if you have a certain brand which is marketing itself a lot, it's like, think about it this way, like, you might have Maggi noodles and you may have like some, say, top ramen or something selling in the shop. Why would you end up getting Maggi and not top ramen? And just because you hear that Maggi every time in the news and in the advertisements and all that, you might pick that up. Or maybe like it could be that the cost is the issue. Maybe it's very hard for, say, for example, small practices to be able to compete with these big brands in terms of cost. So that could be the issue. But I don't agree that that is entirely, the cost and these things. Like you might end up going there, but whether you end up buying a product from there or not is another ball game altogether. So there is a lot of things involved in purchasing hearing aids and decision making, and cost is just one of those factors. Motivation, and of course service delivery, like you saw in those surveys, it's about how you build the loyalty of the patient and all that. So if you are delivering good services and you are building your database, you are building your loyal clients, people will come to you, and there is always going to be competition around. You just have to prove your worth and how your service delivery model is better, and just wait for the magic to happen.
Yeah, surely there will be a spillover. So there'll be spillover from different clinics and other competitors as well. But from a private practitioner's perspective, and if I'm looking at the entire investment that has gone into my clinic for, retaining, sustaining, even developing these clinical facilities, test battery, I need to have the whole, equipment set up, which is not like really cheap here in India. What would you still like comment?
See, I do feel that, like, if you go back to where I started the whole presentation, things that are really that we think we should do are always the hardest to do, isn't it? And sometimes it's all for the sake of professional satisfaction as well, that we do certain things because we know that we're doing things the right way. and maybe the right way may not end up getting the right rewards in the near future, but in the far future, I do believe that it has a lot of value in it. And investing in professional satisfaction can never go wrong, I think.
Yeah. Thank you for that, Imran. The next question is, does rent a hearing aid or any similar returnable model exist in Australia? And in your opinion, does this kind of a model have a future in India?
There are models like that, leasing hearing aids and all that, that are available, especially the Lyric hearing aid works on that kind of a model. I don't know in India how it works, but because it's quite expensive and it has to be replaced so often, that works on like a lease kind of a model, and people just go on a subscription model for it. I don't know, like honestly, it all depends on what your market is, what you want to tap into, and whether you think that's a sustainable model for your particular area, because what may happen in Australia may not really happen in India or anywhere else. So it's different, but at the moment I don't think they are getting a lot of popularity here. Maybe in the future, yes, but right now it's more of a upfront buy models which are more popular. Trials definitely are gaining popularity, but not subscription or leasing models.
Okay. The next question is, like, again, it is quite linked to the earlier question that I asked, is when asked for such value added services and models, clinicians often face the challenge of discount versus service. For example, a premium hearing aid is sold at 50% discount versus a value added service, say in India, 1.5 to 2 lakhs. Do you face such challenges in your clinical model as well, and how do you tackle it?
Yeah, you counsel the patient and be upfront and transparent about your service delivery model. Unbundle the costs, very effective, because if you are telling the person that, look, hey, the hearing aid is actually worth 1 lakh rupees and the rest 50,000 is the cost for warranty and the cost for the services, for the verification validation that we do, for the 2 follow-ups that we give you, the time we invest in you, the clinical expertise, most patients are happy about it. So, being transparent and unbundling the cost definitely helps, in my opinion. And that also helps with competing with these things, because when you have a competitor who is offering the same thing at half the price or 1/4 the price or whatever it is, but your service delivery model is better, and you can explain to the client and unbundle your service delivery versus the actual hearing aid cost, people are happy to pay for it. In my opinion, I can assure you that if you're providing best services, people are happy to pay whatever the cost is, as long as you're being transparent with them about it.
Yes. Thank you, Imran. Next couple of questions are related to equipment. So one question is, what's the investment if you want to buy a real ear measurement system, a dehumidifier setup, and if we have any providers here in India, and a hitbox? So I think we could get some information here from our local dealers. What do you have any recommendations?
We use Oracle. I mean, but I honestly, that's not. I don't work for Oracle, so I can't say anything. But yeah, anything, man. Like whichever you think is workable for you. Like I said, you don't have to invest a lot of money. You look into what is practical for you, but doing it is more important. And of course, there's you start somewhere, and then you see the value in it, and then you invest more and get a better equipment later. So that's what I would say.
Okay, and a dehumidifier setup?
Oh, I think the Redux setup is available on a subscription model for audiologists. I don't know how it works in India, but that's definitely a worthwhile investment, honestly. I think you'll have to get in touch with Redux, or maybe in India, I think the way it works is that Redux might have tied up with any manufacturer for hearing care or something there, and then you'd have to contact them and see if you can buy it upfront. I think you can buy it online as well from them now.
Okay, thank you. The last question, this is now in the chat box, and then I have few of my own. please share guidelines for screening so as to assess auditory processing qualitatively.
Qualitatively. Yeah, there's a good questionnaire that David Moore has created for screening auditory processing disorders. I can send you a link for it. That's actually one of the best questionnaires, in fact, that we've ever had for screening people with, auditory processing disorders. So I think that's the best bet we have at the moment. The questionnaire that David Moore has created with his colleagues in Nottingham.
Okay. Yes, Imran. Now, you did mention that there is this paradox of choice for clinicians as well. Like, when you have too many brands. So what would be your advice like to clinics and clinicians about, the brands that are made available in their clinics? Like, should it be multi? Should it be just one? What goes as per your experience?
In my opinion, it's good to have choice, but then it's good to have some sort of patterns and trends that you follow. So that, say, if I have 5 manufacturers or 4 manufacturers to work with, I know that, okay, if I see a sloping hearing loss, what I'm going to choose. If I see a severe hearing loss, what I'm going to choose. If I'm going to see, say, for example, somebody with a low frequency reverse sloping hearing loss, which hearing aid I'm going to choose. If I'm going to see somebody with Bluetooth, being the center of their, purchase, what I'm going to choose. So reliability, durability. So there's certain trends that you should have as clinicians, in my opinion, that, okay, this brand, this is this subset of clinical features that I need, or this is the profile of the requirement of the client, this brand. If this is what it is, this brand. Because you need to be very clear in your head of what are you going to do in which situation. Because if you are not clear and you are just going there with an open mind, then you're creating problems for both the client and yourself.
Okay. So what is your advice towards the budding ASLPs who are like kind of looking into getting into private practice, or beginners, as to when do you think should be the investment in the entire infrastructure, like which would meet the needs of this test battery that you just discussed? So should I do it now? Should I do it later? Like, and how does it work?
My thoughts are, like when you start a practice, if you want to do something which is professionally satisfactory, then it's better to buy whatever you can afford, and start with a proper, evidence-based practice module, right? Instead of just doing something, it's like doing, in one way you say, oh, let's do one thing really well, and then we'll see. But the problem is, it's in the clinical world, especially with hearing care. If you have to do 5 things, you have to do 5 things. There's no cutting corners, honestly. So if you can't afford it, try with something you can afford first, at least do it. And then maybe invest in something better quality later, instead of not doing it at all. That's probably my thing. Like if you can't afford an Oracle hitbox because it's $6,000 worth, just buy something that is affordable for $1,000. And then maybe in 5 years, once you get a return of investment from that and you have good profits, just invest in a better one later. But not doing it at all will put you at a disadvantage.
Yeah, that's a very, very useful and practical tip. And I think even for our financial models, is like that is what we have to keep into mind. My next question is, just a minute. Yeah. Apart from our today's presentation and expanding horizons has hovered more towards doing hearing aid dispensing and fitting. What other avenues in audiology do you think that the upcoming audiologists can foray into, and then they can make a mark in the field? So do you see any emerging fields in future?
I think auditory processing assessment is definitely an emerging field. Definitely worthwhile looking into that for new ASLPs, because like for pediatrics especially, there are a lot of kids who would have auditory processing disorders which are undiagnosed, and we can help a lot of these people. Is definitely a lot of scope there. Vertigo is another thing that I mentioned in that specialized clinics. Definitely a lot of scope, because right now the whole market is taken over by physiotherapists and occupational therapists, wherein obviously the domain is actually for an audiologist to venture into, because we work closely with the ENTs anyways, whereas the physios and the OTs are not really that close to the ENTs, and it's a domain of an ENT. So why not venture into it and specialize into it? Definitely worthwhile the investment. Of course, if you go into vertigo management and vertigo diagnosis, it requires a lot of time and investment into it. So it has to be a thoughtful investment, I would say. But auditory processing is definitely a slightly cheaper way of getting into something more specialized. Pediatrics, of course, I forgot to mention, like with pediatrics, with hearing aid fittings, RECD is another thing that I would recommend if you're doing pediatrics. Really, are two couple of differences. So if you think, oh look, I can't do real ear measurement with a 3-year-old while fitting a hearing aid because they won't sit still for the whole process. You can do what is called real ear to couple of different measurements. So definitely recommend that. Yeah, I think there's forensic audiology which is developing as well in India. If you guys have sort of focused into that, there's not a lot of things done into forensic audiology, not only in India but across the world. But that's definitely a field that I think will gradually emerge. Cochlear implant audiology is already developed quite a bit, so that's another way of specializing as well. So yeah, there's heaps of options of specializing in all those domains.
Yes, Imran. And surely we are also looking at foraying into industrial audiology, getting tie-ups with industries where they are requiring routine hearing evaluations. We can look into school audiology. We can look into audiology which are related to institutions as well. And rehabilitation is one aspect that we can also look into. Getting into auditory verbal therapy, ASLPs can look into getting specialization into ABT. That's another upcoming, or I would say already there's a huge demand out there. So summing up the whole expanding horizons. So these are different, specialities, or I would rather say in audiology, these are now becoming super specialities. And doing everything for an individual may not be really practical. The way the recent, the fields are emerging and new science and research is coming into play. So I think it's the time where one should really sit down and think for himself or herself, what is it that I'm good at? Am I good at doing a private practice? Am I good at doing an individual clinic? Am I good at developing or becoming an entrepreneur, having a chain of clinics? Or do I want to take up a position in already established chain of clinics and then, go up to the highest level of management also for that matter? So we have audiologists who have done management courses and they have high, managerial positions in different, I would say industry, like the hearing aid industry, hearing aid manufacturers, chain of clinics, etc. So summing up with all these questions today, thank you, Imran, so much. And it was a very gripping presentation. And I thank all the participants for pouring in their question. I hope we have answered all the queries, and still if we have any more, we could probably, take it up on our emails as well. Over to you, Pragna.
Thank you so much. Thank you so much, Imran sir and Neelu ma'am, for a very interesting discussion session, followed right after the vivid presentation. I hope all of our participants enjoyed the session thoroughly. Your questions were answered. Like I said, I requested all of you to stick towards the end of the presentation because we have an interesting announcement. Like we said at the beginning, we Imran sir has very beautifully summed up the clinical perspective of expanding horizons in private practice and audiology. The part two of the same series of expanding horizons will deal with the administrative or organizational perspective. I'm sure even today there were quite a few questions, and again, a lot of upcoming budding audiologists, private practitioners have a lot of questions related to, setting up the clinic or, organizing their practice. A lot of questions related to how do we decide on the clinic space? How do we invest, or how do we plan marketing? What infrastructure do we need? How do we make our financial projections? Where do we invest? Where do we hold back? How do we get a return on all of those investments? What kind of human resources do we need to have from the beginning, and what do we plan in the next 5 years? What are the expansion avenues for us? A lot of questions that are there in our minds, in a lot of in the minds of even experienced clinicians, and especially the budding audiologists. So the part two of our series is going to deal with all of these questions. We are going to have a very interactive coffee with experts session where we'll have a panel discussion with some of the experienced clinical practitioners, especially practicing in a private setup, to answer all of these questions that we have in our mind. So I request all of you to stay tuned for it. We will soon come up with the date and time for it. It will be made available soon. And with this, we have come to the end of today's session. I'd like to, first of all, thank Dr. Imran Dhamani for taking out the time on a Sunday and giving us such an insightful, session. I thank Ms. Neelu Somani Madam for the very interesting discussion round, very interactive and very insightful again. I thank Isha for giving us the platform, for giving us the opportunity for having such discussions. I thank Mr. Saurabh Nauka, the National Coordinator for SIG Private Practitioners of Audiology, for reaching out to Dr. Imran Dhamani for, giving us the idea and pushing us forward on this series. And I like to thank all of our team members in the SIG Private Practitioner for Audiology. And thank you all the participants for joining and making the, the whole session so interesting and interactive. I hope to see you all again in the second part of the series. And I hope you all have a wonderful Sunday and a wonderful week ahead. Thank you. Bye-bye.
Thank you. Thank you, madam.
Thank you.
Thank you, Imran.
Thank you, sir.
It was
Thank you, madam.
excellent. Yeah. The Isha advisors, if you need to be continuing with this meeting, we can. So Shweta? Shweta, do you still need us around? Shweta, you can end the meeting. Shweta, you can end the meeting. Yeah.